You know, one of the things we do on this broadcast is talk about things that health problems that sometimes are a little embarrassing and people really don't like to talk about. And that's where we are today. We're going to be talking about women suffering with leakage, bladder control problems. And it's a very high percentage of women who experience the problem. There is treatment and cure, and that's what we're going to talk about today with Dr. Scott Boyd from Axia Women's Health and Women's Specialty Care of Fort Wayne. Good morning.
Good morning. Thanks for having me.
How common is this problem, really?
The leakage problem is very common. So we can see, up to 40 to 50% of women will have some kind of leakage problems at some point in their life. And we tend to start seeing it around the time of childbirth, and it becomes even more common around the time of menopause and beyond.
I was surprised when you told me how long some women wait for treatment. How long is that?
The average is approximately 7 years from the time that they develop the symptom before they seek out health care for it. 7 years of suffering.
7 years. And why are they waiting?
I think there's a myriad of different reasons for it. I think one of it, the main one that I see is people, it's so common that women think it's normal. And so they'll just sit there and suffer with it, and they won't even bring it up with their doctors, and so they never, get any evaluation, never get any education on things that can be done. So so common, they think it's normal, and then it's embarrassing. It's not something that a lot of people want to talk about, that they're having to wear pads or adult diapers. And then, honestly, when I talk to primary care doctors, a lot of times they're so busy with their patient talking about other things, diabetes, heart disease, blood pressure, that it kind of falls to the end of the conversation and run out of time, and they don't talk about it.
Oh, wow. So if that's such an excellent point. So a little leakage now, again, stress incontinence is something that I think is probably primary, right?
You see a little bit of both. Stress incontinence is where a woman will leak with activities, coughing, laughing, sneezing, walking, running, working out. And then we have a lot of women who have what we call overactive bladder or urge incontinence, and that's usually you've seen the commercials, the gotta go. So where they have a strong urge to go to the bathroom, maybe they don't make it in time, they start leaking before they make it, or they'll have other areas where they'll leak like that, get up at night frequently, not getting good sleep, etc.
So once you identify the type of problem now that leads you to a course of treatment, how often can you help women? What kind of percentage of success do you reach?
I don't like to say 100%, but I've done this for 20 years, and I haven't had a patient yet that we haven't been able to improve. Now, we always tell them I might not make it perfect, but there are so many different avenues and therapies. Sometimes it's real simple, just dietary modifications, education, all the way to medicines and surgeries. So there's big toolbox full of tools for this, and so almost always we can improve their incontinence.
Well, let's walk through that path then. Dietary modifications. What do I need to be thinking about?
There's a lot of things that are known bladder irritants that we all probably like. Coffee is one of my favorites, and it's a very big bladder irritant. And so if you're having bladder problems, that's probably one of the things that you need to look at is your diet, and start eliminating things like coffee, which has caffeines in it, tannic acids, carbonated beverages. The CO2 in the carbonation causes basically acid, irritates the bladder. Spicy foods, chocolate, which has caffeine. So you start with the dietary modifications. That helps for some mild issues.
So let me drill down on coffee for just a second. So is it less coffee in general, cut it out, or to switch to decaf?
Well, decaf, there's always caffeine in it. So there's no such thing as zero caffeine, decaf. And there's other things in the coffee, the tannic acids and other irritants that are in it. So depends on how much you love it. For me personally, if I ever got bladder issues, I would try to find all my workarounds possible and do decaf and half and other things. But it's probably best to eliminate it if possible.
So now let's move on to the next step in that process. If I can't get it under control with dietary modifications alone, then what?
A lot of times women are pretty well versed in something called Kegel exercises. Certainly could Google it and figure that out. So I always tell people on their own, do your dietary modification, do your Kegels. If that fails, excuse me, then seek out your medical, primary care doctor, your nurse practitioners. Start discussing it with them. Most primary care docs are pretty good with medicines and early phase treatments. And
as a matter of fact, a text question here is somebody asking how effective Kegels are. How many per day do you need to do to make it effective?
You know, it depends on it's not going to be very effective for an overactive bladder, which is more of the urgency issues. It's pretty effective for the stress incontinence early phases, and for younger patients like after delivery, Kegel exercises are very good for that. If they do it a couple times a day, what I always tell people is, if you're watching TV, every time a commercial comes on, do your Kegels while the commercial series is going on. So, 5 minutes or so, and then do that for half an hour. So, you get a couple of sets of 5 minute rounds in half an hour period of time. Do that a couple of times a day, and you're going to be in good shape.
And I understand that's the same is true for men if they're having bladder problems, right? Kegels work for men as well.
Kegels work for men. It depends on their issues, but they tend to have more prostate problems, which Kegels may or may not work. But certain things are even good for men.
Another element in this text question: what is the AZO product? I don't know anything about that.
Yeah, AZO. Actually, it's a line of different bladder products. It's all over the counter. Some of it's for overactive bladder. Some of it's for bladder infections. It kind of is some numbing agents. Some general bladder health with probiotics. So they have there's probably 4 or 5 different AZO products out there. I've had good luck with it. I'd recommend, looking into those for women if their incontinence isn't very severe.
And let's move into procedures now. If I have a problem that I can't get under control with these things we've discussed so far, then what?
Again, it kind of depends on if it's, we could take stress incontinence, which is a real common one. That's usually due to a weakness in the pelvic floor muscles and the pelvic floor ligament supports underneath the urethra and the bladder. So if you do your Kegels, you can try a formal physical therapy approach. So we have several physical therapists that do pelvic floor physical therapy for women. In our group, we have a pelvic floor rehab process as well. If that fails, then surgical techniques are basically slings, which are little pieces of plastic netting that goes underneath the urethra, and or bulking agents, injectables into the urethra, which are very effective as well.
Where do I need to start? If I'm this is not normal. I'm living with this problem. It's not normal. Can I just call and schedule an appointment with you, or do I need a referral in?
Nope. Call and make an appointment. You can come right to the urogynecologist. If you have a good relationship with your primary care doc, and you're seeing them, certainly start that conversation with them. But you can see us anytime. Just give us a phone call or get on our internet and find us.
What is the most important piece of advice you can give to anybody suffering this problem right now?
You said the word right there, suffer. I always tell patients, don't suffer with this. I see patients all the time who have been afraid to go see their kids graduate high school, afraid to go to church, afraid to leave the house. They're altering their lifestyle constantly, and they're suffering with it. If it gets to the point where you're suffering, seek help. There are way too many good tools in the toolbox to fix this. You should not be suffering with this.
We've got to let you go. That's Dr. Scott Boyd from Axia Women's Health, Women's Specialty Care. Time went very quickly here, but on the other side of the commercial break, we're going to go another step in a different direction here with Axia Women's Care, and that is going to talk about the midwife situation. Did you know midwives are still very active and increasingly so? There's a lot we don't know, so we're going to find out more as we continue here on the Health Call Live Radio Hour. And if you do this segment, we're going to be talking about midwifery with our guest, Becky Compton, also from Axia Women's Health, Women's Specialty Care. How do I say that correctly?
It is midwifery. It is the midwife practices midwifery. It's funny, even midwives, before we go to school, a lot of us don't know how to say it properly as well.
Okay. So a midwife is going to assist me through pregnancy and the birth process. Tell me why I would choose that.
So a midwife is a certified nurse midwife is a person who has a nursing background, has been a nurse first, typically either an associate or a bachelor's degree, and then continues on with a master's degree program in midwifery or community-based midwifery, and then sits for a certification exam through the American Midwifery Certification Board. So it is a national certification. And so then you understand when you have a CNM or a certified nurse midwife that there's a level of expertise, but you also have the nursing background, which is a more personal approach based on education and bodily autonomy. The term midwife means with woman. Mm-hmm. They go back to biblical times. You see, midwives in the Bible. we have learned through the process that women want that personal approach. They want to be respected. They want to be heard. They want a little more time to understand what their options are. And that's one of the benefits of having a midwife, is that personal care. But it's not just for pregnancy. It's not just for birth. I see patients all the way from the very first, menstrual cycle. They're confused and don't know what's going on, and can provide that support and education all the way through menopause and beyond. My scope, typically, I typically see people during those childbearing years, but it is available beyond as well.
So give me an idea of, in the birth process, what is your role? What are you doing for me?
So I am the care provider for the woman in birth and in labor. So it's the same as like a nurse practitioner in a family practice office, where they can see everybody and they can prescribe and they can manage the care. With midwifery, it's like a nurse practitioner for labor and birth. It is the person making those medical decisions, choosing interventions while supporting the mom through labor, birth, and beyond. There's other support roles beyond midwifery, such as doulas, that can be a part of the care team, but the midwife is the medical provider.
So tell me about, I have read that if I have a midwife caring for me during pregnancy, I'm less likely to need an epidural, I'm less likely to have an episiotomy, that I'm more likely to have that natural birth that so many women want, and that you make it so much easier.
It has a lot to do with time and support. Women in labor have this amazing phenomenon that when their body is in stress, things tend to slow down or shut down. And so by feeling trusted and supported, it allows the natural process to unfold physiologically, the way that our body is supposed to. Pregnancy and childbirth are a normal, healthy part of a woman's life. The beauty of the program that we have at Axia is that I am an expert in low-risk birth and low-risk pregnancy, but I have wonderful physician partners that are available to co-manage and collaborate with for certain high-risk situations. So then a woman who, may traditionally not be what we, call eligible for midwifery care because they have a high-risk condition can still have that approach as well, where they can be co-managed, still get the support of the midwife during labor and birth, but still have the medical care from the physician.
So if I'm not a high-risk pregnancy, I am eligible for your care?
Correct. Yep.
And where do I choose that along the way? If I'm just starting out, just find out I'm pregnant, or if I'm midway term and I'm not happy with how things are rocking on my other team, can I come on board? Where does it matter? At
any time. We like to start as early as possible, just because it is a relationship, but I am available at any time. If you decide that you're not jiving with the care team you're with, just, call the office and set up appointments, and we'll, continue your prenatal care through your delivery and beyond.
One of the issues that I have heard women talk about often is, I'm concerned that when my time comes, my OB is not going to be there for me, that I might have a doctor I've not known before actually handle the delivery. Does being involved with the midwife cure that problem?
So there's still a small window that, lives happen and right. Sometimes people are unavailable, but I do my best, and as I'm building the midwifery practice with Axia Women's Health, is to provide that midwifery care for the birth for those patients that desire it. Because so often we are in situations, I know with my own children, I've had the on-call provider, and so it is my best effort that those that desire a midwifery birth are able to get one.
So give me an idea of what you're doing that's different, innovative, new, that if I might not know about.
So one of the things that I am specialized in is it's called Ktaping. A lot of people have heard about kinesiology taping. It's the same principle. It's using a cotton and elastic tape to help support the body. There is research that, we get a lot of our sensations through our skin, and it goes through the layers of the skin, through the muscles. And Ktaping has 4 different primary functions, where there's a muscle tape, a fascia tape, a ligament tape, and then a lymphatic tape. And so there's different techniques based off of what needs may be, whether it's you have swelling feet and we tape up your legs to help the fluid drain off. You're having symphysis pubis dysfunction, so your pelvis needs that extra support. We can use a tape technique for that. Having low back pain, there's a tape technique for that. So it's a non-pharmacological, non-medicalized way to support the body to help through some of the discomforts of pregnancy, and even after, even mastitis and some diastasis rectus, so abdominal separation, all have little tips and tricks with taping.
Oh, that's interesting. So a more kind of organic way of dealing with those problems. Don't throw pills at me. Let's approach it differently. I think that would appeal to a lot of people. So where do you stay with me after the birth and helping me get through those issues around early, that neonate area?
So typically we will do the standard 6-week postpartum visit in the office. However, I make myself available for office visits for any kind of breastfeeding issues, any kind of postpartum blues. I like to have a check-in. I feel like a lot of times we get to know our obstetrical provider so intimately during those, months and weeks leading up, and then it's almost like a breakup afterwards. So I try to do some follow-through with, both postpartum phone calls and then also those availability for those issue type things that come up between when baby comes and then those 6 weeks.
Yeah, this whole baby formula shortage has really brought breastfeeding to the fore. And I think a lot of people have had their eyes open to how this is it's a natural process, but it doesn't necessarily come easily. How can you help?
So it's a learning process. I mean, your baby's never done this before, and, sometimes you've done it before, sometimes you haven't. So making sure that there's a good latch and assessing that latch early and often is very important. That affects how much milk comes in, how, there's any kind of cracking of nipples and discomfort that way. And so it's not just a one and done. It is a continuous, as baby is growing. Sometimes baby has some issues with a tongue tie, lip tie. Sometimes there's issues with mom's anatomy with, inverted or everted nipples. So it's working together. There's nipple shields, there's nipple shells, there's different kinds of techniques that can be used to assist the latch. And when it boils down to it, that is the key to a successful breastfeeding journey.
So I get it. I'm feeling that a primary benefit is I have more time with you. It's a more personal kind of experience. I like the way you put this. It's not medicalized. That is great. So I would assume that once a woman has a experience with a midwife, they come back with their subsequent children, don't they?
A lot of times, yes.
Yeah, I'll bet that's true. What is the thing that most people maybe don't understand about midwifery, besides how to say it, of course?
So I think one of the most common misconceptions is we think of midwives as crunchy granola Birkenstock wearing, as I sit here with my Birkenstocks on. It is a medical modern approach, not medical, but a modern approach to a medical situation, that we are in the hospital, we have the technology available, but we also have the roots in the old school. We know the movement, we know the education, we know those true secrets that I think a lot of physicians don't have that opportunity because of time limitations.
Right.
And so it creates this beautiful picture that we have a marriage of the traditional and the modern together.
Well, I think that's where we're going to have to leave it. But I get the sense of you as being a very caring, kind of relaxed person, just exactly the kind of person I would want to have on my team if I were going through that. And thank goodness, as a guy, I don't have to, right?
Thank you very much.
You bet. So that is Becky Compton from Actually Women's Health, Women's Specialty Care. And I want to remind you that Dr. Boyd is going to be hosting a webinar on women and bladder leakage. And you can go to the website, axiawh.com, and find a link there where you can register for that webinar. It is coming up June 21st at 6 p.m.